So this is a triplet study of azacitidine, venetoclax, and gilteritinib for patients with FLT3-mutated AML. And so the rationale is that, well, it's in the frontline setting for older patients who are unfit for intensive chemotherapy. The standard is now azacitidine plus venetoclax. Now, even for those patients who have a FLT3 mutation, it's not standard to add a FLT3 inhibitor for them. We know in younger patients that the addition of a FLT3 inhibitor improves outcomes for those patients who have a FLT3 mutation. This hasn't really been explored in older patients who we now give azacitidine venetoclax. We know for those patients who have a FLT3 mutation and get azacitidine venetoclax, that the outcomes of those patients with FLT3 mutated AML are suboptimal. The 1-year survival rate is between 40 to 60%, depending on whether they have a FLT3 TKD or ITD mutation. So gilteritinib is a potent FLT3 inhibitor that's approved in the relapsed refractory setting. And so the purpose of the study was to bring that into the frontline setting to combine with azacitidine venetoclax. And we also evaluated in the relapsed refractory setting to see if we can improve the outcomes of patients with FLT3 mutated AML as compared to gilteritinib alone, to do the triplet combination in that setting as well to see if that might improve outcomes. So we've treated 47 patients in the frontline setting, 27 patients in the relapsed refractory setting, 20 patients. So in the relapsed refractory setting, we have a response rate of 70%, which seems better than what would be expected with gilteritinib alone. About half of those responses are CR or CRI, half are MLFS. The median survival still is only about 5.8 months. Now, part of that may be because we enrolled a lot of patients who had had prior exposure to hypomethylating agent plus venetoclax, and including some patients who had prior gilteritinib. So if we exclude the patients from the analysis who had had hypomethylating agent plus venetoclax and or gilteritinib, the median survival is 10.5 months, which seems a bit more encouraging. Now, I think where this is really exciting is in the frontline setting for the older patients, 60 years of age and older, who are considered unfit for intensive chemotherapy. So again, we've treated 27 of those patients. So we've seen all patients respond, and 92% of whom achieved a full complete remission, and 82% achieved MRD negativity by flow cytometry. And so for comparison, in the BIALI-A study that led to the approval of azacitidine venetoclax, if we look in the FLT3 cohort from there, the CR rates are about 30 to 50%, versus we've seen 92%, which is, again, I think very exciting. In the frontline setting, among the 27 patients, we've transplanted 7 of them. There's been 4 deaths overall, which is translated to a median one-year survival of 85%, and the median survival has not yet been reached. So I think we're very encouraged, particularly in this context, because this seems to compare very favorably to our historical expectations with patients with FLT3 mutated AML who receive azacitidine and venetoclax without a FLT3 inhibitor. Again, the 1-year survival in that population with azacitidine and venetoclax is around 40 to 60%. We'll need to see longer-term follow-up, but right now our 1-year survival is 85%, which certainly numerically is higher than the expectations. So I think where this regimen has the most promise as far as being used by others in the future would be in the frontline setting. I think one of the challenges what we have found is that combining gilteritinib or any FLT3 inhibitor really with azacitidine venetoclax causes a lot of myelosuppression. So I think importantly what we've done in the study is we have used lower doses of these drugs. So we do, for example, during induction, we do a day 14 bone marrow. And for those patients who are in a marrow remission, which is the vast majority, we actually stop the venetoclax and gilteritinib early to allow for count recovery. And then in cycles 2 and beyond, we actually use lower doses of azacitidine venetoclax. So I think it's important that we've been able in the study to find safe doses of these drugs to deliver what we know is a very effective therapy. And so I think what I'm most excited about is the promise of this triplet regimen, again, in the frontline setting, because we're seeing such high rates of response and the survival certainly looking better than our historical expectations. I hope with longer follow-up and more patients, we can make a convincing argument that this should be a standard of care that can be used outside of our academic center for patients with FLT3 mutated AML. So the study continues to accrue patients. Obviously, we need longer-term follow-up because we can see later relapses in patients with azacitidine venetoclax. So if this is maintained in the longer-term follow-up, and we're still seeing a 2-year survival of 60, 70% or higher, that would certainly make a very convincing case that this was a more effective therapy than azacitidine venetoclax in this FLT3 mutated population. One thing that we also hope to do moving forward is to use more sensitive MRD assays. So we'll retrospectively go back to some of these samples and use more sensitive MRD assays to look for clearance of those FLT3 clones. I think the goal would be to hopefully we can also show that this regimen is really eradicating, at least at a very deep sensitivity, eradicating these FLT3 clones.